Okay, Ed, feel free to start.
Thank you. Okay, so good afternoon. Welcome to this EFIC COVID-19 webinar. And as you can see from the screen, the topic for this afternoon is on digital approaches to pain management during the COVID-19 pandemic. My name's Ed Keogh. I'm one of the hosts this afternoon, along with Mary O'Keefe. I'm based at the University of Bath in the UK, and Mary is a research project officer for EFIC. And as you can see here, we'll have two panelists today who will be giving you their insights around digital technologies and the way in which that may be applied to chronic pain. In terms of the overview for today, what we'll be doing is give you two presentations, 15 to 20 minutes each. And then what we'll do, we'll have 15 to 20 minutes towards the end, where we'll be able to ask questions and engage in discussion. What you'll hopefully see in front of you is a Q&A button. And on the Q&A button, you'll be able to present various questions as we go through the presentations. You'll also have the option to rate these or rank these in terms of order of interest or what you'd like to be answered first. So you should be able to see these and obviously rate these and help us in terms of which questions to ask towards the end. So we'll go straight from the presentations to the Q&A at the end. Hopefully that's clear. I'm going to stop sort of talking and really move straight over to our presenters, and I'll start with our first presenter. And so I'm sort of absolutely delighted to introduce Dr. Thomas, Professor Dr. Thomas Tolin from Munich, and as you can see, has background in both psychology and neurologist, and as you can see, that also has contributed a lot to EFIC, and is very much going to be talking to this afternoon around the development of a sort of a new medical app and the applications there. So, Thomas, over to you.
Yes, Ed, thank you. And now you transfer the rights to me?
I have indeed. You should be able to share your screen.
So, Ed, Mary, thank you very much for inviting us, Chris and me, to give a presentation to discuss with you the potential of telemedicine and the use of apps and virtual reality in times of pandemics. And I think it's very well taken that you say in times of pandemic, because as you can see from this presentation here, the COVID pandemic is called the black swan for mental health care and turning point for e-health. And this is probably the case. Many of us have thought about it and thought to pick up these new ideas that are included in these digital medicine techniques. But then the COVID pandemic initialized a lot of progress, and EFIC was always behind it. You can see here what the SIP, the Societal Impact of Pain from EFIC, added to the 9th framework. They made suggestions, and they also said that e-health should be included, and that there should be an initiation for the development of mobile health technologies for patients empowerment, self-care, multimodal approaches of pain treatment. So in EFIC, this is a long-lasting tradition already for years now, if that is already tradition. But also nowadays, in the Global Year of Pain, in which we perform together with ISP in 2022, there is a section of innovations in physiotherapy and digital health. And so it's more than rational that today also we speak about digital apps and also virtual reality, which is picked up here as an example. And if you speak about digital apps, then if you look into the internet, for instance, what I have done again now in preparing for you, you find not only a plenty, you find hundreds, maybe many hundred different applications which could be called digital applications for support of treatment of pain or treatment of pain. Many of them are lifestyle. and would not fulfill the criteria that we need for our business, for our professional business in pain treating, the physicians and group of psychologists and physiotherapists. However, if you look into this systematic review and the meta-analysis, this group in 2019 said that if you take impact guidelines as a criterion, then there is a positive outcome from their observations that maybe clinicians would treat patients with chronic pain and they could consider e-health and m-health intervention. Maybe, Chris, are you still picking up the point of all these different wordings? I was not willing to take your review, which would have been optimal because I thought you might present it. So m-health would be mobile health, like from smartphones and so on. And that they think that it could be part of a multidisciplinary pain treatment strategy. If you then think about it, a multidisciplinary pain treatment strategy, it means that you as a doctor maybe take advantage of something like m-health to support your patients. However, what we know, if we go deeper into this, and let me concentrate on back pain for my part of the talk, then we know that there is a multidimensional aspect of chronic back pain, and that we have to consider that we have, at least as we say, three big pillars, the biopsychosocial backgrounds of pain. And in the most optimal and elegant way, this is in screenshots from pain center in Munich, where I work, that we have a multidisciplinarity, like doctors, psychologists, physiotherapists, but we have also multimodality. And at the moment, EFIC is, just so that you know, also having a discussion round, an ad hoc group to differentiate on multimodality and multidisciplinarity. But that is what we think. And now we come back to our starting point, pandemic. So at a certain point, I got the ring from the head of our clinic, and he said, you can send all people home. And of course, this is very dissatisfying because these people have waited for joining such a group for maybe months, but we had to send them home. In this condition, we were very lucky that we had started 2 years ago to transfer all these, what we perform in the multimodal pain treatment in our reality with patients in small groups into a digital version with a group, with a company Kaya, and we made a Kaya app, which would include physiotherapy, relaxation techniques or mindfulness techniques and education, and that we would by itself then be in such one app, unless the other apps that are available which do not offer this, that we could be a multimodal right away. The educational content was oriented to what we normally tell people in different levels. Relaxation would include different techniques, and the physiotherapy, of course, we had a special view on, because we said that you should not just perform exercises, but you should also get motion coach advice, like you would be, like a good physiotherapist would do, that you would get advice whether you move correctly in order to get a high quality and standard of your movement and exercise. And we also took advantage of techniques where you can, if you make a construction of a 3D pose from a 2D image, that this is a technique which Apple offers in a very, very difficult algorithm, that you can make such kind of a rotation, and then you can, as a coach, even correct things which are normally hidden if you have a person which you just see in a 2D image, to let you just have a feeling how the patients are guided in such a program. So you see that you have this grid which is over your body, and which then is everything is controlled technically. Like here you have the hunched back, and then you get the correction. You are advised that you change, that you take your back straight. And this is not done if you're... So we thought that this was a big advantage, that you not only are instructed to do your exercises, but that you're also corrected in order to get high quality. And these exercises are now available in a motion coach with nowadays 115 different exercises. In order then, when we developed this, to really see whether we could bring it to our patients, we did first a retrospective analysis. And we could see that in a reasonable high hundreds of patients group, that you get a substantial reduction of pain level here in the overall group. But if you have patients that adhere to the program for 12 weeks, then you get a more substantial reduction of pain as an outcome. We then thought, can we really do this without checking and bring it to our patients without comparing standards? So for pity, this is just in the German version, but I can explain this. We did a randomized controlled study, app versus the standard of care, and our standard was to have 6 units of physiotherapy with an excellent professional physiotherapy team, which is standard in Germany. And at the same time, you would get information about your back pain disease over 6 weeks by being sent selected high quality internet links. And the other group was just getting the app where all the 3 components are included. If you then look into the data, you can see at 6 weeks this is still even, but then after 12 weeks that the group using the digitalized version is improving significantly over this group, which is getting the standard of care in Germany. In the next step, then, to really make us convinced that this is an application that we can bring to patients, we initiated a big study, which is called Rise Up. In English, I would translate it with the back innovative pain therapy with eHealth for our patients. It has various components. So there's a therapy navigator, we call it, where you're instructed how you perform a treatment algorithm according all to the guidelines, which are almost the same in England and Germany. I know. We established a GP network of 110 GPs around Bavaria, collected 1,250 patients, and 900 were put to the intervention group and 350 into the control group. And in the intervention groups, they got the medical app for patients, and then there was telemedicine for those ones, which showed a high risk for developing chronic back pain with the Start Back tool. If you then go into this kind of study and you have 1,250 patients to manage, we had data after 3 months, how this would perform, and we now have data after 12 months. And what we can see is that the overall reduction in the NRS rating is about 2.5. If you go to the percentage of pain reduction, you see after 1 year, you have 46% pain reduction. This is steadily increasing over time. And the control group, which is receiving standard of care now, so the GPs were allowed to do everything what they have in mind according to the guidelines of treating unspecific back pain, and they would never reach a clinically significant reduction of pain. This is not only the pain which is reduced, but you see also that functionability under the condition of being treated with an app is much more improving. that the well-being is better in the group which is having this digitalized treatment, that the anxiety, depression, stress is decreasing while it is increasing in the control group, and that the patient satisfaction is also increased with this digitalized version of a back pain treatment than they would receive from a GP in a standard condition. Another step for us, of course, was how would that relate to the exercise achievements that the patients perform. So we have the data of 900 patients. We did an AI analysis, which would try to make the best fit of how the user behavior would be, and we could find 4 groups. You see those ones just shortly exercising, a little bit longer, decreasing, and being on a high stable version, and the plots which show not only the use behavior but also the reduction of pain, shows that every of these different behaviors will achieve the same reduction of pain, and this is achieved with all conditions of behavior. So this, I think, is a guidance for the next development of relating also to patients, that obviously every group of patients is making their own decisions what would be the best for them. And now we could, of course, interfere with those ones in order to achieve a better performance and a better login and access to the different pillars of the app. Last aspect would be that you can see, if you make a cost analysis of the routine data that we got from insurance companies of all these patients, that you see all these bootstrapping data fall into one little, in the lower left quadrant, where you see incremental effectiveness, so reduction of pain and reduction of costs. So what you get also with this kind of electronic treatment, that the healthcare costs in control group increased by 204 euros, while in the Rise Up Digital group it was reduced by 39 euros. And if you make a cost effectiveness analysis, you make savings of 420 euros per point reduction of the NIS pain scale. This is, I think, very fundamental, and this is a reasonable saving to our healthcare costs. Summary: this Rise Up digital treatment with medical app shows clinical superiority, economic superiority, and higher patient satisfaction. And I think we have one particular fan. I must say, I haven't met him, but it's fun. You see, this is Joshua Patterson, and he did the marathon run. And I don't know why he came onto this. He was running Rise Up. I think I must get in touch with him and ask him what was driving him. I think he is very convinced. If you go into our patients, this is now my last slide, then there's a big difference between what patients think and what doctors think. Doctors still, this is older work, there's no newer work available. In writing, physicians think this is superior. They want to have more telephone, and they want to have more in presence. But if you look into the patients, what is asked here, email and online interaction, then patients prefer this definitely, and physicians don't like it. And I think this, of course, has to say something. Clinicians were less positive about using electronic communication and all these tools, and this is different. And so this, if you think about your health system, has to say something what we have to bring in order. The future, this is what we have summarized in this fact paper, is that interdisciplinary healthcare teams could use the data, and that the treatment plan could be then to integrate other modules from medicine and psychotherapy to be in the biopsychosocial model of chronic pain. And these were thoughts that we had since long in Germany, in our group, who has developed Rise Up and co-developed with Kaya this medical approach in digital medicine. Where do we go in the treatment of chronic pain? And I think this is something that we have to have in mind. There is a patient still in the center of all this. There's the GP, we have a medical team with all the disciplines, we have coaching of the patient to perform in the app, we have a management team. And so I think these new techniques, the digital mode of the patient being on himself, training himself, deciding when to train, and the team accessing him with further information, questions, and support is probably what I think what mHealth and what digital medicine means to me to treat chronic pain. Thank you.
Thank you very much, Thomas. Excellent. That was a fascinating overview of the work you're doing. Thank you very much. I have these 5 or 6 questions which I've written down as you were talking. I remind you that the Q&A box is open, so please do feel free to add a few questions there. I will now move on to introduce Chris Eccleston to you, who's our second speaker, who is also based at the University of Bath and is the director of the Bath Centre of Pain Research, psychology, has medical psychology background, and we're talking about developing VR interventions. So over to you, Chris.
Thanks, Ed. Thanks, Marion. It's great to be here, and it's great to be working with you, Thomas. And I just want to say I'm just a great fan of the work that you're doing, and I've been privileged to follow the development of Kaya and what you're doing, and bringing such a strong empirical base to it is what really sets it apart from a lot of the other noise that's out there about digital apps. It really is an incredible achievement. But what I want to do in the small amount of time that I have here is to sort of provoke some conversation and debate amongst you. And please do use the Q&A or the chat or whatever it is, and let's get some debate going. Because quite frankly, we have a problem as a field. I probably shouldn't be speaking so boldly to this audience, because you're an audience who cares. You're an audience who've come along to have the conversation about innovation and digital development and doing things differently. So why should I speak to you in this way, other than to try and practice some of these ideas and invite you to help in trying to promote change and to provoke change, because we have a significant problem, and the problem that you're fully aware of looks something like this, in that you'll remember, as part of EFIC a number of years ago, we did an audit of all of the existing infrastructure across a generous definition of Europe of 38 countries in this European Pain Management Review. Some of you will have been involved in this review. We asked every country to tell us what the population prevalence of pain is, what the types of issues that they're dealing with in terms of presentations. We asked you to tell us about your infrastructure for the way you're set up to deliver pain care. And we asked you to give us examples of innovations and things that you're proud of, but what also the challenges were. And then we looked across them. And there are a number of features that came through, and this book is freely available. If anybody for some reason doesn't have a copy, then let me know and we'll send you a copy free of charge. This is your work, as it were. There are a number of things that came through that perhaps I didn't spell out very clearly. One is the epidemiology, which I'll talk about in a second. But the other is that there are a lot of the technological and organizational and knowledge infrastructure that we have across Europe to deliver high quality pain care is fragile. It's fragile in the sense that it's often built on a short history. It's built in the shadow of individuals who are pioneers of their time and are still often mentioned. It's not, the knowledge isn't yet shared across enough of the population of medics and other healthcare professionals. It's often siloed. A lot of the complaints that people had, regardless of the country and its size, were that we couldn't persuade our colleagues to think differently about pain, that there was huge and growing waiting lists. And as soon as we add a new population of professionals, then their waiting lists get filled very quickly. And in a way, it's because the supply of the sort of expert knowledge that you have will never come close to meeting the demands that we have as a population. If there are 740 million people in Europe alone, and a conservative estimate of 20% of them having chronic pain that could be helped, that's 140 million people, which is the population of France and Germany combined. And even if you say that's a little overly aggressive form of epidemiology, if you took a small proportion of those who are the most severe patients who might benefit from the type of knowledge that the 45 people on this call have, then we're never going to even get close to meeting their needs. We won't even scratch the surface, as it were. It's not even an iceberg. It's just a tiny proportion of people. And that got me thinking quite radically about what I do as a pain professional and what we do every day. The problem is worse than that. It's not just that there's a lot of unmet need. The problem is that where we have high quality evidence supported treatments, like physical rehabilitation, like the physiotherapy and back pain that you're seeing that Kaya have just presented and Thomas has just presented, like cognitive behavioral therapy, for example, all these nice randomized controlled trials that are done and these systematic reviews that me and other people write demonstrate that there are effective treatments, but there's an odd inverse relationship between the treatments that have the most efficacy and safety are the ones that are used least. And the ones that are most dangerous and most easy to use, and let's look at the dual opioid crises that are going on, are the ones that people have most access to. So we have this wonderful, if you like, perfect storm of a problem where we know that there are people that we can help, but they're accessing, I'll put this out extremely, and then we might get some questions popping up. Let me make it as extreme as possible. Is that we've created a system, or we operate in a system, or we are tolerant of a system that promotes ineffective treatments to the masses and denies access to the effective treatments. And why is that? It's not because we don't care. It's because our models of delivering treatment are archaic, or rather Victorian, or rather old-fashioned in some ways. And more recently, I've come to think, just to be challenging to you, I've come to think of chronic pain management potentially as a luxury good. You'll remember from your training or from high school, if you like, what the definition of a luxury good is: supply increases, as demand increases and supply stays the same, so the value of it increases. And it doesn't matter whether you're doing this as a chronic pain management professional, or you're doing this, just to give you some stereotypes. Perhaps it's starting to look a bit like this. It's only the small number of people who get it. And that, ladies and gentlemen, is where technology comes in. And that is why, hopefully you're here, is to thinking how perhaps in our lifetime we could radically change the treatment models and the approaches that we have. So we could flip this rather odd situation so that we're able to deliver those treatments with evidence at scale and reduce the harm of being overexposed to dangerous and ineffective treatments. Now, just to chime with what Thomas was saying, this is not a new argument. This is something we've been talking about for a number of years. Other people have been talking about, mental health professionals are talking about. But COVID really accelerated this debate and this discussion and changed it a little bit as well. I hesitate to say that there was anything even remotely positive about COVID. It was a horrible few years and we're still living through it in many ways. We lost people, you lost people. It was, there was nothing positive about it. One very, very thin silver lining approach to this particular discussion is that we managed to, as Thomas said, across the world, almost overnight, people were closing their doors to chronic pain patients and saying, what can we do? Can we switch to digital interventions? So the debate changed, and it wasn't one of how do you do it? Or is that really appropriate to do? To how fast can we do this? So we tried to help in a small way. We wrote this paper trying to help people who are thinking about shifting their treatments over. And what was interesting was people were arguing that, well, it won't last, people will go back. And Thomas has already mentioned some of that resistance, especially from professionals, is still there about exactly how far you can make things digital and not, and whether the treatment model is changing. But actually, it was revolutionary. Almost overnight, people were not asking the question, can they make this as good as a face-to-face intervention? They were suddenly asking different questions like how do I improve it? How do I make it better? And in a way, that's what technology is potentially good at. It's good at increasing access to existing treatments. But more than that, it might also be good at improving those treatments. It's not, the question isn't just, can I make it as good as a face-to-face interaction? The question is, how do I make it even better? Let me be very clear, I'm a psychologist, so from a psychology point of view, if you were inventing psychotherapy-orientated treatments for chronic pain, or even physical therapy interventions like the one that you've just heard, you wouldn't start where we started. If people are carrying these things around with them, these telephones around them, they have access to these devices, they would do something different. You would start from a different place. And that's what we're hoping to promote and allow things to happen. When I set up the Bath Pain Management Unit in 97 or 98, I think it was, which is a residential treatment center for adults and later adolescents with chronic pain, running off a national model. This was a really important book for me. It was produced by Mitch Cohen and Jim Campbell, and it argued that pain treatment centers were at a crossroads, and there was a need for a conceptual reappraisal. And some of that crossroads was about, at that time, was about multidisciplinary care and interdisciplinary care. I suggest that perhaps we're at a new digital crossroads, and maybe we could talk to Ethic, or Thomas and I could actually run this meeting again and create a new crossroads, a new practical and conceptual reappraisal that is needed. And we've argued for this in a number of places, most recently in our Lancet commission on pediatric pain. We argued, and it ends with this proposal to redesign pain services, putting at the very heart of pain services the knowledge not in people's heads, but in an expert system that can be delivered in multiple ways. And one of those ways in which we've argued it could be delivered is through virtual reality interventions, as you see there on the right-hand side. Now, VR, of course, is at a very early stage of development, even as I show you this Oculus device, which is the state-of-the-art current commercially available device. Even in a year's time, this is going to look old-fashioned. In 10 years' time, it'll look ridiculous. So it's not about the current systems that we have. This conversation is about opening the door to novel and unusual and effective ways of doing things differently. But we have to try, we have to start somewhere. Luckily, there's guidance in this area. Some colleagues of ours from the US, particularly Zina Trost and Chris France, who has a long history in this field, Manima Anam and Corey Shum, who's a technologist, put together this really very nice paper. If you don't have it available, only published 2 years ago, which is basically a heuristic model or a way we can start to think about virtual reality processes in chronic pain. Now, historically, of course, most of the VR interventions have been in acute pain settings, and they've been really focused on using the immersive qualities of virtual reality, sort of high hypnosis, high involved distraction ability that virtual reality can do. And that was where a lot of the early studies have been used and are still being developed in those areas. But more confusingly, and perhaps coming later was how you might have a virtual reality intervention in a chronic pain setting, where you're not, by definition, it's not only for an intervention or a procedure or to distract somebody in a short amount of time, it's for a longer period of time. What they did and what you have in front of you is try to pull apart some of the configuration factors of what might be used in the particular device and the factors associated with that device. What's the audio quality? What's the background sound? What sort of visual presentations do you need? What's the physics of actually wearing things, etc. All of those hardware components, if you like, separate from the user experience factors that are critically the big four that all of these interventions adopt. This high immersive quality, and what I mean by that is if you've never used one of these devices, that you really have a sense of another reality, that you really are immersed fully in it. You're not constantly thinking it's a representation of something. You know it's not real, but you're in that sense of being fully immersed in something. So much so that you feel a presence, that you're not thinking backwards or outwards or thinking about what's outside it. You feel that you're presenced within it. The different levels of interactivity within these devices so that you can actually engage with virtual events that are happening. And the lastly is the level at which people want to express or experiment with what's called embodiment. And that can really be in two ways. One is actually embodying you as a user. It might be a limb, so you look down and see a leg, or you see your own arm interacting in the world, like in a phantom limb intervention. Or it could be an embodied mentor or an embodied trainer or an embodied coach or an embodied therapist in some way. So those four features are those that have emerged in this heuristic model as being really quite important. And then, of course, with the hardware and with those factors, then there are multiple targets that you could use them in. It could be about changing beliefs. It could be about changing emotions. It could be about all of the above. It could be about having direct physiological effects in relaxation, for example, or it could be really goal orientated. It's the opportunities are enormous. So that, if you like, is a framework. I'm going to give you one example, but not labor it, because hopefully we can have some discussion around this. We recently, I think perhaps that's why you asked me to do this, developed a treatment which has been accepted, a randomized controlled trial of an embodied virtual reality intervention for adults, which is now Impress coming out in pain, I think the next month. So there's the paper. This was a randomized controlled trial that was run with our colleagues in Finland. So it's actually run in Finnish. It was it's a treble blind trial because it runs with an automatic mentor delivering a behavior change intervention over a 6-week period. So the mentor themselves doesn't know which person's been assigned to the treatment compared to the non-treatment control or the sham control. The patient is unaware of whether they've been assigned to a sham control or not, and the experimenters are unaware because the whole thing is blinded. So it is a double blind from a triple blind randomized control trial. The sham intervention is quite interesting because in this case we chose a non-agentic virtual reality intervention. So simply people going into a space and exploring the space without the behavior change content being built into it. So it really is a mechanistic test. And one of the things that we were able to demonstrate in this pilot trial is that the primary focused outcome, which is fear avoidance beliefs, so changing people's fear of movement, was the most effective outcome, as well as reducing their disability, not changing their pain at all. I haven't gone into the details about this trial, A, because you can read it, and B, because I don't think that's what today's discussion is about, although that's quite interesting. Today's discussion is really about what's the future for these types of virtual reality instantiations of treatments, especially when they're fully automated, which means that they don't need an interpreting therapist or interpreting healthcare professional who in the moment is providing that feedback. They can be completely scaled up if they're effective, if they're useful. Not suggesting that's an easy thing to do. You have to get devices to people. You have to have it realistic. It has to be working. But the possibilities of making us less of a luxury good, I think, are starting to emerge. This we got the cover of Pain, so that will come out in next month. So that's what the next month's cover will look like. Here's an example of not actually the version that we had, of the next version, so you can have a sense of it. The problem of presenting virtual reality interventions where you're moving in 6 dimensions and it depends on an immersive presence quality in 2D is that you lose all of those immersive qualities. But I'm going to show you a 2D, a video clip anyway, but please be aware that it's very different to what that experience might be actually like. This is an example of one of the 4 spaces that when you enter this world that you would be able to do. And what you'll see that what we're interested in on the right is our colleague is showing you what's happening, is that you're in a really quite terrifying, fearful inducing environment, and people are needing to move towards a particular goal. And if you have a back pain, you're not thinking about that pain, or you're just thinking about what it is that you're actually doing and being exposed to those environments. So that just gives you a taste of these types of environments. So I'll show it again. One of the other things that we're particularly interested in doing is playing around with the idea of whether we should embody the mentor, the guide, or not. In other words, when you're in this environment, should you have somebody who's actually talking to you in a particular way with an embodied feature or not? And we've been exploring that, and this is a paper that's coming out hopefully soon in Frontiers in Virtual Reality, where we're playing around with this. I'll give you an example, a semi-autonomous mentoring intelligence, or called SAMI. So there's someone who can actually be in that space with you and can deliver those treatment interventions, has facial expressions, is interacting with you, fully automated way, rather than just having a disembodied voice. So I'm just play. This is the idea of where some of this work might go in the future. Let's think about what some of the problems might be, or some of the ideas might be. So as some of you will know, we presented this at EFIC and you were able to experience it. People were interested in it. I was quite pleased that people were open to the idea, but they're the ones who came along. So my challenge to you and to us, and before I stop, is that how do we think about redesigning pain services? How do we get out of our comfort zone and start to think about shaking things up? Obviously, I'm an enthusiast. I'm thinking about it in that way. I'm not focusing on all of the many problems. I'm being a very bullish, positive view of the future. I'm not here to sell you this individual intervention. What I'm more interested in is what we can get to in 10 years' time and how it might be different. Just as a quick advert for those of you who are in Toronto, we're going to have a debate. I've challenged Frank Keefe to a debate. Frank Keefe, some of you will know, is a very well-established, very successful and very important pain psychologist. And I've said to him, I want to debate with him. We're going to have a fight night, and I'm going to debate. And the debate question is the future of psychological assessment and intervention in chronic pain will be wholly digital. And I'm going to argue that it's wholly digital, and he's going to argue that it will never be wholly digital. Come along on Tuesday the 20th. So thank you very much, and I'll pass back to Ed, and then hopefully we have provoked you into a conversation. Thanks.
Super. Thank you very much, Chris. Okay, so we can now move over for about sort of 10-15 minutes of Q&A, and obviously the Q&A box is open. I will kick off with a question of my own if I can. And which is probably bringing back down to earth, Chris. I mean, you're talking very positively. So I'm going to start on the, what about this? What about that? I mean, one of the things I think you both alluded to was this. First of all, there's a lot of upfront work that needs to go into the development of these sorts of applications, digital applications, and of course, you sort of alluded to it, Chris, that the technology goes out of date very quickly, and I just wondered, that's clearly a challenge. And I'm wondering, do we need to rethink the way in which we fast track these sorts of devices, or is there a huge risk there? Any sort of thoughts on how we get around that particular challenge? That's open to both of you.
You may have to tell us which one to speak, probably.
Chris, you can go first, as usual.
Okay, so yes, you're absolutely right. There's a dominant, if you like, pharmacological development model which says that you have to do preclinical work, and then you have to do, which means animal work, and then you have to identify the molecule, and then you have to stabilize the molecule, you have to translate it into human work, and then only after a long period of time does it get into a treatment safety studies, and then you might have a 10-year patent. But at that point at which you stabilize it, it does not change. It doesn't work in technology. That's not how we work at all. So you have this sort of fast-growing try it and fail cycle where you can actually to be developing something incredibly quickly. You're absolutely right. What we've shown will now be out of date and continues to be out of date. But again, I see that positively, because what you really need is a technology. Think of the active ingredient. I'm trying to think of this a different way. Almost as if it's a molecule or an active ingredient that is constantly changing and learning, is improving. So the nice thing about this device, and the same is true, I think, for Thomas, is I know how long people spend in each room, how long they spend thinking about each content. I know which utterances work and which don't work. I can alter them in the moment. You can change it for the individual patient. You can alter it over a longer period of time. You can keep improving. You can have a constant cycle of improvement. It's not frozen. So in some ways, I would take that challenge and I'd say, that's actually one of the more interesting features of this. So we need to innovate and develop a personalized therapeutic approach in which you can use that learning to constantly improve the outcomes in a way that we could never do with the treatments that we had before.
Thank you. Thomas, any add to that?
Yeah, I think there are many points Chris picked up, and it would be, of course, fun to discuss this. And Chris, maybe really one should make such thing as a revival story of 96. How will this develop with new techniques? And I think the most fundamental point that Chris raised in the beginning, I must comment this, I cannot not do it, is the scaling. If I see my pain center here, I can maybe, not speaking about pandemia, but in normal conditions, maybe I can serve with a multimodal 20-day program, 100 patients in a year. A colleague of mine at the other university, they can make another 100. Out there are thousands and 100,000. We know this. And many of them just get access to anything which is coming to pain treatments that we would accept as a starting point only after years. And I think these techniques is the first very important point. And this was also a big motivation in my work, that the pandemic came over was not expected. Anyway, I thought that these patients that have an early problem and where the GP can maybe then support them with this multimodal approach of education and relaxation and physio, that this would make changes. And of course, these multidisciplinary pain centers of highest level, they would not get away. But this is, Chris, also an important point. Many people that I have spoken to say, well, do you want to get rid of us? No, I said, I want to get your time for these very complicated patients. So this is the first point, and we could discuss this lengthy. Then the next point is individualized treatment. Yes, this is all AI driven. Also our app, depending on your health status, on your performance, on your daily capacities. It will adjust the program, and will take the exercises where you have a problem in a later point. We recommend that you do this reading. So this is absolutely crazy. This is sometimes more than a good therapist can keep his eyes on. If he has 10 patients, that he is really individualized treating him. This is one thing. But so discussion could be long. There is one point, Chris, and I don't know whether I will make it for your debate. Is this in a certain point of time, don't know how many years, fully automatic, or is it now? So what we know at the moment, and of course these people change, also the time frame where I am working in this condition, this is 5-6 years now, people have changed, opinions have changed. Doctors' opinions have also changed slightly now. But still, the case is that patients accept this nicely, but they want to have this handed out by the healthcare professional. This can be a physio, this can be a doctor, this can be a psychologist, because it's gaining more trust. It wouldn't mean that the doctor or the psychologist or all the healthcare system members would have to heavily interfere when he is working with the tool that you give out. But he must, it's still, this is his opinion and my own observation, they still want to have the idea that this is supervised in a way by someone who is having not the time, but the capacity to oversee this. And I think from this point, maybe then if we are in the end avatars, it doesn't make, we don't need it anymore. But in the moment, I think there must be still an interaction, in my opinion. And there's others where we are pretty much overlapping. And as we spoke about this in Dublin, I think we also have to think about platforms. Like there would be absolutely no problem to collaborate with virtual reality on the app format that we have done, and that you pop it up, and that you let the patient decide what is worthful for him, and so that could be like a toolbox where you in the end take out what the patient demands at the time. And still, I think, Chris, that could be the need of a doctor, that if there is medication necessary or something, that this could be a major point. But I think we are starting like now. But I think if I need pain therapy, hopefully not tomorrow, then probably we have this kind of easy adjusted complex treatment, and multimodality will then mean something completely different that we now mean. So it's an open field, and it's fantastic. I can just emphasize to every young pain therapist that he should be interested in.
It's great that you raised some of these questions, though, because I really don't want to give the impression at all that we're trying to replace anybody. In many ways, it's the opposite. It's
but people think
it's about shifting expertise out of individuals' heads, that you have to get on public transport and go and visit them in some faraway city for your 200 people, and getting that expertise into an expert system that can be delivered in multiple ways. I think I might have made a mistake, not that I want to put you off the debate by agreeing to argue the most extreme position.
But Chris, sorry, this is also kind of an imperialism, because we know that what you said, it's a luxury good.
Yeah.
If you have achieved it to come, let's say, into a center like ours, people say, "Oh, I did it."
Yeah.
But they also know that hundreds and thousands and neighbors will not make it.
Yeah.
And there is countries, not only in Europe, but all over the world, they will never, ever in their life have anything like which is coming into just close to multimodal therapy for their pain, and they have the same pain. And the only thing is that they all have before they will get a roof on the in South Asia or where they get a roof over their head, they will have a mobile.
Yeah.
And this is imperialism. And there are still people that I know and that I can see that say, keep things close, don't open it too much.
Yeah.
And this is really saddening.
We are preaching to the converted, aren't we, Thomas, I think? But you are right, even within Europe, 140 million people in Russia alone as a country, and their access to even the most basic pain care is minimal. This is the problem. This is why EFIC exists, to sort of embrace new ways of doing things. Ed, we're getting excited here. You have an audience.
There's a question here from the audience, from Roger. Hi, Roger. Do these treatments require any approvals for routine use? So that would be virtual reality applications or the digital apps.
Yeah, well, if I start quickly, and then Thomas is actually the expert in Germany. So VR they will. Well, it depends if you decide to go direct to consumer, as it were, or whether you go in the prescribed route. And currently, FDA in November last year created a route for, not based on our interventions, but based on Applied VR, which is a company out of Stanford who developed they've created the pathway for regulation through FDA, and the EMA will follow. In terms of apps, I'll pass to Thomas, because actually Germany is the leading, with DIGA is the leading authority in that.
Yes, I think for everything which you apply to a patient, you must get some certification that you are not doing harm to people, even if you what we call sell it B2C to the consumer. You are not allowed to sell everything if it is obviously harming him. So this has at least to have some level. And if you then want to get reimbursement, then you have to fulfill all the standards, which is, of course, very high. And obviously, Germany is having kind of trying to do kind of a standard. So what do we have to fulfill, like an RCT, or it's like a regulation when you would license a drug until you will get reimbursement. And this is fair, I think, because there might be exercises that you have thought about which is bringing people into trouble, not only with the physical exercises, but also for you, Chris. I would expect that if you have a patient which is having the risk of dissociation, and he's looking into his Googles and he's getting, wow, maybe getting a panic. So these things have to be excluded before you bring people into access to this. And this is good. This is absolutely good. And this is very different in all countries. And maybe we get some unification, but EFIC also could promote this at a certain point for Europe, at least. And yes, but it needs standards.
Thank you. Something, Mary, perhaps you could go back to EFIC in your role and suggest. I think we've run out of time, unfortunately. I think I'll have to bring it to a close now. I'd like to say thank you very much to Chris and Thomas for some fascinating talks. Mary, thank you also for helping out and sort of helping moderate this, and also thanks to EFIC for putting this on, and such an interesting afternoon. Thank you, and obviously thank you also for attending today.
Thank you. Thanks the team for organizing all this. Thank you.
Thanks, Chris. Thanks, Thomas.
Bye.
Thanks, Ed.